Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the redesigned Sonicision Curved Jaw Cordless Ultrasonic Dissection Device. The cordless design reduces the challenge of managing cords in the sterile field and provides freedom of movement and mobility during your surgical procedures, contributing to a safer and more efficient OR. Available in 4 shaft links to help meet your specific need, the Sonicision Curved Jaw Cordless Ultrasonic Dissection Device enables secure vessel coagulation and efficient dissection in open and minimally invasive surgical procedures. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision Curved Jaw device has an improved reusable generator that is now autoclavable and enables 1.5 times more procedural uses than the legacy device. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse, and provides an 88% increase in battery capacity, which may mean fewer procedural delays due to mid-case battery exchanges. The Sonicision Curved Jaw Cordless Ultrasonic Dissection Device. Feel the freedom.
Yes. Okay, good morning, everybody, and welcome to this session of Upper GI of Esophago-Gastric session. It's my immense pleasure to introduce my co-chair, Dr. Jimmy So from the National University Hospital, and we have an exciting lineup of speakers today. And without any ado, I would like to introduce our first speaker. He's Professor Hyang-Oh Kim, the Professor and Director of Surgery in Seoul National University Bundang Hospital. And he has been the principal investigator in the Class 1 trial, as well as currently the Sentinel Navigation Node trial. He's one of the pioneers of laparoscopic gastrectomy in South Korea. And very importantly, he's been my mentor, friend, philosopher, and guide. So with immense pleasure, I would like to introduce Professor Hyang-Oh Kim, who's going to speak on laparoscopic gastrectomy for stage 4 stomach cancer.
Thank you, Dr. Lau. I'm very happy to have a chance to share our experience for laparoscopic surgery for stage 4 disease. Let me try my slide.
Yes, we can see now.
Okay. Okay. I have no COI for this presentation. Thanks to Legata trial for the stage 4 disease, the Korean guideline and Japanese guideline recommend palliative chemotherapy alone as a standard treatment. Palliative surgery is only allowed to alleviate symptoms, not for prolonging the survival. However, some investigators still believe surgery has some role for selected cases for stage 4 gastric cancer. Here, in treatment consult diagram provided by Professor Yoshida, suggested that alveolar surgery could be performed in non-macroscopic peritoneal disease, and volume reduction surgery could be possible even in positive macroscopic peritoneal dissemination. If patient showed good and effective response to preoperative chemotherapy, including IP chemotherapy. Let's share our experience for stage 4 disease. Here, the patient, 35 male patient, years old male patient, he had peritonitis due to gastric cancer preparation, 3 advanced before. So you can see here on type 4 advanced gastric cancer and many lymph node, perigastric lymph node, and seeding is here. So we did purpose chemotherapy 6 cycle. After 6 cycle FOLFOX, CT shows the tumor burden was slightly decreased. I'm not sure. The radiologist said the tumor burden is decreased, but still many lymph nodes and peritoneal seeding is existed. So we did diagnostic laparoscopy first, and we can remove the primary tumor and a whole seeding nodule by partial peritoneectomy and peritoneal nodule ablation by Bobby. You can see here many tumor nodules in peritoneal seeding here, and tumor is here. So we did peritoneal biopsy first. Here, the nodule is here. And we did proton biopsy. The proton biopsy shows the tumor cell in here. After that, we take down the tumor from the peritoneum and the liver. And here, the peritoneal seeding, so macroscopic peritoneal seeding in the left subdiaphragmatic area. So we excised partial peritoneectomy. And also, we ablated this small tumor nodule by albumin coagulator. I skipped whole video due to time limitation. Oops. Sorry. So last 15 years, we reported our 15 years experience of the laparoscopic gastrectomy for advanced gastric cancer. We analyzed the short-term and long-term outcomes. We did 1,500 patients successfully underwent laparoscopic gastrectomy during last 15 years. So here, the mean operation time was around 3.5 minutes, half hours, and most patient, around 70% of patients had T2 lymphadenectomy, and the mean retrieved lymph node number was 60. Among 1,500 patients, the stage 4 disease was 63 patients. It was 4.2%. So you can see here the 5-year overall survival rate in stage 4 disease was 25%. Yes, this is a relatively resectable stage 4 disease. So anyway, the 5-year overall survival rate was 25%. Here, in 64 patients in stage 4 disease, the intraperitoneal seeding was 60%, and 20% had positive peritoneal cytology, and 6% of patients had distant organ metastasis, including liver, ovarian, appendix. And 10% patient had para-aortic node metastasis, and 8% patient had station 14V metastasis. Also, we compare laparoscopic gastrectomy with open gastrectomy for stage 4 disease. Here, we analyzed 500 stage 4 gastric cancer. 347 patients was excluded due to peritoneal biopsy and bypass surgery only, and etc. So finally, we analyzed 115 stage 4 gastric cancer, including 36 laparoscope and 81 open group. We use propensity matching to fixed compounding factor. So finally, we analyzed 36 laparoscopic and 36 open gastrectomy. The mean age was 55, and the male to female ratio was 50:40, and mean body mass index was 21. Here, the 70% patient had D2 lymphadenectomy, and 40% patient had combined resection, and 60% patient had total gastrectomy. The mean operation time was around 4 hours, and 20% patient had intraperitoneal chemotherapy. The mean retrieved lymph node number was 70. So 70% patient had peritoneal metastasis, and 25% patient had distant lymph node metastasis, and 6% had distant organ metastasis, and 20% positive washing cytology, and 35% had negative cytology. In post-operative complication, there was no statistically significant difference between two groups, but the complication rate curve shows less tendency in the laparoscopic surgery group. The complication rate was 6%.
Prof, we may need to summarize.
Okay. One or two slides left. the laparoscope, the 5-year overall survival rate was, of the laparoscopic group was 23%, and the median survival time was 18 months. Open group was 25 and 22.8 months. So no statistical significance between two groups. Palliative chemotherapy cycle, and post-operative complication was prognostic factor for overall survival. When we look on the load of the maximum surgery, you can see here, Legato trials, 2-year survival rate was 31% in chemotherapy alone, 25% in surgery plus chemotherapy. Our study, 2-year survival rate, which was the same criteria of the Legato trial, was 55.6%, and the median survival time was 20.8 months. It was 1.8 times than Legato trials. So conclusively, laparoscopic gastrectomy with maximum metastasectomy in stage 4 disease was comparable with open surgery, and it was safe and technically feasible, and it needs mandatory post-operative systemic chemotherapy, and it has some lower in certain patients, even peritoneal and distant to metastasis. It should be approved by RCT. Thank you very much for your kind attention.
Thank you very much, Prof, for this excellent lecture and pushing the boundaries of gastric cancer management and providing state-of-the-art care. We'll save the questions to the end in the event of time, and I will introduce the next speaker, who is another very good friend of mine, Professor Do-Jung Park. He's a professor at the Seoul National University Hospital and College of Medicine in Seoul, as well as Bundang. He's also a very prominent laparoscopic surgeon involved in many trials, and he's a primary investigator for the Class 5 trial, which is laparoscopic proximal gastrectomy versus total gastrectomy. And today he's going to talk to us about laparoscopic proximal gastrectomy for early gastric cancer. Professor Park?
Thank you, Dr. Rao, for your kind introduction. It's my great pleasure to be connected with everyone. I'm honored to talk about laparoscopic proximal gastrectomy for early gastric cancer. This is my disclosure. I'd like to introduce laparoscopic proximal gastrectomy with especially double track reconstruction today. The first retrospective result, and second prospective RCT, and followed by short-term outcomes. With Professor Hyung-ho Kim, our institute changed the anastomosis method from direct esophagogastrostomy to double track reconstruction, because direct esophagogastrostomy has many reflux esophagitis and resulted in the anastomotic stricture. After change of double track reconstruction, there was no severe reflux esophagitis. And this double track reconstruction has advantage because it is applicable to any proximal early gastric cancer and even Gibert type 2, the high located cancer. So I prepared a short video clip about laparoscopic proximal gastrectomy, open the omentum, ligate to left gastric triploid vessels and short gastric vessels, and clear all soft tissues, including lymph nodes along the common hepatic artery, left gastric artery, and splenic artery. And using laparoscopic pulse string clamp, we cut the esophagus just the same manner as your open method. And then this is the final view of lymph node dissection for early gastric cancer. And insert M-wheel into the esophagus stump and extract the specimen and identify the tumor location and transect the stomach extracorporeally. We can transect the stomach intracorporeally. It depends on the surgeon's preference. I cut the jejunum for preparing the anastomosis. First, make jejunostomy extracorporeally and close the common opening. And this is a remnant stomach and the jejunum. So gastrojejunostomy is made and close the common opening with the thread manually. And finally, insert to circular stapler the jejunal stump and insert circular stapler in the abdomen and making the pneumoperitoneum again and make esophago-jejunostomy with a direct view of the laparoscope. This is the final view of anastomosis. This is esophago-jejunostomy, and 10 or 15 centimeter below there is a gastrojejunostomy, and 20 centimeter below jejunostomy. This is another video clip of robotic proximal gastrectomy, the same as the lymph node dissection method. So I skipped it and clearing the greater curvature side for transection of the stomach. And transect the stomach with linear stapler intracorporeally, different from the previous video. Completion of all lymph node dissection, I transect the esophagus and jejunum for anastomosis. This is a gastrojejunostomy procedure, and close the common opening with also linear stapler, and then carefully make esophago-jejunostomy with linear stapler. In order to prevent some stenosis, I prefer manually suture the common opening with a barbed suture. And finally, jejunostomy was done. The order of anastomosis depends on the surgeon's preference. And finally, I closed the mesentery defect with the barbed suture. So all anastomotic procedures is finished. This is esophago-jejunostomy, and 10 or 15 centimeter below gastrojejunostomy here, and also 20 centimeter below there will be jejunostomy, just as a laparoscope procedure. Based on our gastric emptying scan, the majority, 60% of food passed through the remnant stomach, and the other 40% passes through directly into the jejunum. We compared the laparoscope proximal gastrectomy with the double track reconstruction and laparoscope total gastrectomy. There was no significant difference of complication, including reflux symptom and stenosis between two groups. However, the double track group has advantage of less hemoglobin change and more preserved vitamin B12 level, and no difference in terms of overall survival. So we designed the multi-center prospective RCT comparing this proximal gastrectomy with a double track reconstruction with laparoscopic total gastrectomy. A total of 138 patients were randomized into two groups, and the primary endpoint is hemoglobin change and vitamin B12 supplemental quantity. So we had the first investigator meeting 6 years ago, and we conducted the surgical quality control for better the trial. And finally, 25 investigators from 14 institutes are participating in this class trial. And successfully, we completed the 2-year enrollment 2 years ago, and 2-year follow-up is ongoing till this year, September or October. So I'd like to show briefly the short-term outcome regarding operative morbidity and mortality. There was no significant difference of morbidity and mortality between two groups. And we are waiting for the final long-term outcome. So in summary, laparoscopic proximal gastrectomy with double track reconstruction is acceptable for proximal aortic gastric cancer and good option with no severe reflux. Short-term outcome, no difference. And class 05 will give the final outcome in late 2020. Thank you for your kind attention.
Thank you, Professor Do Jun Park. Yeah, let me introduce the next speaker. My name is Jimmy So from Singapore. Our next speaker is Dr. Jaideep Rao. I think many of us know him well. Jaideep is actually a senior consultant surgeon at the private practice. He formerly was the head of upper GI surgery at the Dundalk Singh Hospital, and also the ex-president of our Obesity and Metabolic Surgical Society of Singapore. Therefore, Rao is going to speak to us on the tips and tricks in robotic Ivor-Lewis esophagectomy. Rao, hand it to you now.
Oh, I'm out of the speaker's room.
Let's try again.
Can somebody let me in?
Yeah, you are in. Maybe while waiting for Rao, I just can ask some questions. And I have a burning question for Do Jun.
Yes, please.
Congratulations for your completion of your randomized trial. We are looking forward to the final result. Therefore, I think the trick is the anastomosis of the esophageal jejunostomy. Therefore, you demonstrated two techniques. One is using the circular stapler. Another one is in the linear stapling techniques. And how do you choose these two techniques?
Thank you for your very important questions. So, if the anastomotic level is relatively low, I prefer the circular stapler. The laparoscopic pulse string clamp lap jack, which was, and if the anastomosis is level is high, circular stapler is very difficult. Yes, we can do with the oval, but sometimes they're not comfortable. So if anastomosis is relatively high, I prefer the linear stapler overlap method. Thank you.
I see. Therefore, I think the organizers, thanks to John, told us to proceed to the next speaker first while Rao is settling some administrative issues. I think we'll go on to Professor Law's lecture first. I think, is it okay, Simon? You please unmute. Therefore, let me introduce Professor Simon Law. And I think Professor Law is a professor and chief of esophageal and upper GI surgery from the University of Hong Kong. I think he's a very well-known surgeons, upper GI surgeon in the world, I think, and he also a pioneer of many esophageal cancer surgery, including minimal invasive esophagectomy. Therefore, today we're going to talk about his vintage point on minimal invasive esophagectomy. Professor Simon Law, please.
Thank you, Jimmy. Well, we've only got 10 minutes, so we really can't talk much on the subject. So I'm really just going to tell you some of my thoughts. So just to share with you the minimally invasive esophagectomy around the world. You're probably aware of this study. It's a big group of us, experts and dedicated centers around the world, led by Donald Low. This is looking at the current situation of what's happening with MIE around the world. So when we did this data, this was published in 2017. At that time, we had just under 3,000 patients, 24 centers in 14 countries. And as you know, that at that time, roughly 50% of all the esophagectomies done in all these centers around the world are done by minimally invasive approach. Now, what are the evidence? I'm just going to review the key couple of trials for you. This is a time trial, very famous, minimally invasive esophagectomy versus open esophagectomy, a multi-centered European trial. The primary endpoint of the study was pulmonary infection rate. And the VATS group with the prone position with laparoscopy with the cervical anastomosis versus a open surgery. Now, at that time, it showed the number of patients that are recruited is only around 60. And these are the characteristics of the patient. But even with that small number of patients, they were able to show a significant difference in terms of the primary endpoint. That is pulmonary infection rate, whether at 2 weeks after surgery or whether in the hospital stay, was much, much better in the MIE group compared to the open group. Recurrent laryngeal palsy rate was somehow higher in the open group. But in any case, this was a very influential trial showing that minimally invasive esophagectomy has advantage over the open esophagectomy. This is the French trial, 13 French centers, 200 patients, mid and lower third tumors, and both squamous cell and adenocarcinomas were included. These were the inclusion criteria. And the primary endpoint of the randomized trial was a Clavian grade of 2 or more. Now, this is an interesting trial because the two groups, they were comparing laparoscopic gastric mobilization with an open thoracic esophagectomy versus an open gastric mobilization and open thoracic esophagectomy. So the minimally invasive part of the surgery was only the laparoscopic gastric mobilization, and both groups have open thoracotomy. And even with that, they were able to show the complication rate was better in the hybrid group. So major complication rate was 36% versus 64% in the open group, and major pulmonary complication was 18% in the hybrid group versus 30% in the open group. Hospital mortality rate was similar. So from these two trials, it showed that totally minimally invasive approach was better than open. A laparoscopic component that added was also better than open esophagectomy. Now, what about robotics? This was the Dutch trial published in the Annals of Surgery last year. Again, it was a robotic minimally invasive surgery versus an open transthoracic esophagectomy. Primary endpoint, again, complications. They hypothesized that there was a 22% reduction in complications, and they came up with this randomization number, which was actually very similar to the time trial. And again, it showed a significant difference. The RAMI group was better in terms of a lot of these complications, operation time, blood loss, and so on and so on. So again, it showed that the minimally invasive technique, whether you do it by thoracoscopy, laparoscopy, or robotic, was better than open surgery. Now in Hong Kong, there was a time trend of what we have been doing. Multimodality treatment over time has increased a lot, as shown by the blue line, but also for VATS esophagectomy, we started actually quite early, but we were rather disappointed with the early results. But in the mid-2000s, we decided to give it another bash. We added on the laparoscopy as well. And so the number of laparoscopic and thoracoscopic esophagectomy has gone up. And currently, it's roughly about 60 to 80% of oral esophagectomies are done by the minimally invasive approach. Now, our standard approach is by VATS in the left lateral position, and then followed by laparoscopic gastric mobilization. Typically, we do a complete two-field lymphadenectomy. With the selected patients, we will do a neck dissection as well. And routinely, we will put a stomach up to the neck for a cervical esophago-gastrostomy. So this is our standard technique. Now, just to show you a video, we've got 3 minutes. So 10 minutes, we can't show you the whole operation. I'm only focused on the superior mediastinal dissection during the bilateral recurrent nerve dissection. This is a nerve stimulator that we use. We boast both a intermittent nerve stimulation as well as a continuous nerve stimulation. You can see the recurrent laryngeal nerve on the right side. The lymph nodes are taken posterior to it. So this is actually pretty high up. As you can see, the subclavian has come back to its normal position, and we actually way up in the neck. So again, just to confirm the integrity of the recurrent laryngeal nerve. Now on the left side is more difficult. The trachea is retracted anteriorly. So this is to look for the recurrent nerve. This is the edge of the trachea. Again, this is the nerve that we found with a nerve stimulator. Sharp dissection, mostly with a pair of scissors to avoid heat injury. You see this patient has a lot of small lymph nodes behind the trachea. Now the continuous nerve monitoring, if we are putting traction on it, the latency will be increased. Sometimes the amplitude of the nerve conduction will be reduced as well. And we've been using this continuous nerve monitoring for quite some time now. It does give us a real-time feedback of the health of the recurrent laryngeal nerve. So again, this is dissection around the nerve. You see all these lymph nodes here. This is in fact in the subaortic area. This is the pulmonary artery. So the energy source, if you want to use, you have to be very careful not to transmit the heat energy towards the nerve. Again, you can see the nerve here. The lymph nodes around it has been taken away. So you see dissecting the lymph nodes just around the recurrent laryngeal nerve. The trachea needs to be pulled anteriorly. And usually this part of the operation is the most difficult. So completing the operation, the right recurrent laryngeal nerve, just to confirm the integrity. This is the left recurrent laryngeal nerve, the lung on the left side. And this is the arch of the aorta, the recurrent nerve going down here, and the pulmonary artery. We didn't show you the infracarinal dissection, but this is just to tell you what happens after the complete dissection. Everything is spared. That's the aorta. We see the lung on the other side. We routinely resect the thoracic duct as well. So this is a stump. And so this is completes our thoracic part of the operation. Now, what about robotics? So we've been trying to do robotics as well. Now this is our patient positioned. We don't do a fully prone position. We do this sort of 45 degrees position with the surgeon anteriorly to the body. We feel that this position is easier to place rather than the fully prone one. And should you need to convert, then it's easier. The patient has a single lumen ventilation with a blocker. And we do it with 8 millimeters of artificial pneumothorax. So just again to show you the superior mediastinal dissection, that was ICG, a little bit overspill, but you could see the lymph node there. So these are the, you can see this is the nerve, just identified. This is the subclavian. And for robotics, we would mainly just use a pair of sharp scissors rather than using the energy source provided by the Da Vinci. So you can see this is the trachea, and this is the paratracheal area. Again, this is a little bit overspilled again. So this patient has quite a few lymph nodes, small ones in the paratracheal area. So we're extending down to the right recurrent laryngeal nerve area down here. So this is the whole complex, if you like, is the right recurrent laryngeal nerve lymph nodes coming down to the paratracheal lymph nodes on the right side. We have a gauze behind, so this is the lymphatics with areolar tissue that we take away. And so you see that's the paratracheal area dissected, that's the vagus nerve, and going up here will be the recurrent laryngeal nerve lymph nodes taken away. Now next we turn our attention to the left side. So this is the trachea. We first dissected just posterior to the cartilaginous part of the trachea. Again, we want to find a nerve. We actually connected the nerve stimulator to the scissors. You can hear the voice, but we're using the scissors also to test for the nerve integrity as well. So firstly, dissected just behind the trachea. You can see that's the left recurrent laryngeal nerve in the sort of midst of areolar tissue, using a pair of scissors to dissect the lymph nodes away from the recurrent laryngeal nerve. One of the arms has the esophagus pulled up. The other arm using this to retract the trachea anteriorly. So basically it's a one-man operation. This is, again, dissecting the tissues away from the nerve. We're very cautious about using energy. So again, this is the nerve. So now we are separating the nerve from the esophagus. You can see the nerve here and the lung on the other side. And this is actually just a bit of fat. There's no lymph node inside actually. So you can see the trachea being pulled back. That's the left recurrent laryngeal nerve, lung from the other side. Again, just to test the integrity with the nerve stimulator. That's why I'm touching it with the scissors. Okay, and in my view, it's not very much material to compare robotic assisted esophagectomy with open. I think we have plenty of evidence now. When we want to compare robotic with the VATS, I think this is the way to go. And this is a multi-center trial initiated by Dr. Chow from Taipei. I think it's a very interesting endpoint. It's the rate of unsuccessful left recurrent laryngeal nerve dissection as defined by failure to remove the lymph nodes along the left recurrent laryngeal nerve, and as well as the permanent palsy rate at 6 months. And this trial is still ongoing. The aim is to recruit about 200 patients. But I think, in my view, the benefits of the robot, potential benefit is really the superior mediastinal dissection. As far as the inferior mediastinal dissection is concerned, it really doesn't matter what methods you use. Just a brief word about our recurrent laryngeal nerve palsy rate with the use of recurrent laryngeal nerve monitoring. This is when we started to do the recurrent laryngeal nerve monitoring. As you can see, this is the recurrent laryngeal palsy rate. It has gone down quite a bit since the start of our using the recurrent laryngeal nerve palsy, the recurrent laryngeal nerve monitoring. The permanent palsy rate, in fact, has gone right down. And we did a multivariate analysis of the factors that may affect nerve palsy. And of course, if you have neoadjuvant chemoradiation, that makes it more difficult. And upper third tumors, again, of course, it makes it more difficult to dissect around the recurrent laryngeal nerve. So a very brief talk. My summary, I think MIE is here to stay. It's basically now is the standard. Around the world, 50% of esophagectomies are done like this. I think it's already good evidence from our CT and meta-analysis that whether you do VATS or laparoscopy or robotic, they are better than open esophagectomy. Of course, you need to select your patients carefully. There are still a couple of questions. This is often asked, okay, whether you do it in the lateral or the prone or semi-prone position. I think my take to it is that it really doesn't matter. It depends on what you like to do. And if you're happy with it, you're happy with it. I think the benefits of RAMI is still needs to be assessed. It is equivalent, I think, at least to MIE. It is, of course, more expensive. So if you really want to justify that, I think that randomized trial showing the efficiency of dissecting around the left recurrent laryngeal nerve is very important. And I think we look forward to that results. That's all I'm going to say. We welcome any questions later on. Thank you.
Thanks, Simon. Okay, thank you. We'll put the questions later on at the end. Now we move on to Raul. Raul, are you ready?
Yes, I'm back.
And sorry about that. Can you see my screen?
Yep.
Okay. So I was asked to talk about robotic Ivor Lewis, and Simon has given a fantastic overview of, in general, robotic esophagectomy, mainly 3-stage. And basically, as you all know, esophageal surgery is very challenging because the main issues of access, post-op pain, lung infection, and trying to reduce leak rates, especially Ivor Lewis surgery. So it started with, of course, thoracotomies, laparotomy, and now went into VATS, and now advantages of the robot. And that being that the main problem in VATS, I feel, is because the ports are in between the ribs and there's very little maneuverability, especially while doing anastomosis, whereas robot provides those wristed instruments that help in that, and which we'll see the videos later on. And these were some of the early pioneers who did robotic esophagectomy. And one of my mentors here, Sir Folio, showed that actually one of the advantages of robot was you can actually reduce the leak rates by changing from stapled anastomosis to hand sewn. And he's shown that in his rates now almost zero when he's doing hand sewn anastomosis. And even the learning curve is much shorter, about 15 to 20 cases compared to laparoscopic, which is much higher. So this was for gastrectomy. Professor Ahn showed that it just takes about 20 cases to get past the learning curve, and blood loss is much lower. This is again from Yingkai Changkeng, rates of recurrent laryngeal nerve palsy when comparing robot versus VATS, and that's just takes 50 cases to become an expert and see those improvements. So my own personal journey started doing first things like leiomyoma, nuclear excision, and then I started doing hybrid, where I did the abdominal part laparoscopic and the thoracic part robotic, and then to full robotic. Initially, I used to do circular and linear stapling, and now I've started doing mainly hand sewn, and I found it much better. The abdominal port placement are very similar to that of gastrectomy. The camera is in the umbilicus. You have one on the left side and two on the right side, and you have an accessory for your assistant to help with things like clips and staples, etc. The abdominal part involves beginning at the pars, dissecting around the hiatus, then entering the lesser sac through the gastrocolic omentum, then dividing the greater omentum, preserving the right gastroepiploic vessel, dividing the short gastrics. Some of the things that I've learned is that actually when you keep a piece of omentum, you can use that later to wrap, and that decreases the risk of anastomotic leak. Also, if you keep a a narrow tube, just about 4 or 5 centimeter, it actually improves gastroparesis, improves gastric emptying, and also thus decreases leak rates. I've stopped using jejunostomy tubes. And then the chest, of course, we enter through the 8th intercostal space. These are the ports for the SI system, but with the XI system, you can place everything on a straight line along the 8th intercostal space. So the chest dissection, of course, involves the pulmonary ligament division, the pleura, and then dissecting the esophagus from inferior upwards. Last time, what I used to do was actually deliver the specimen into the chest and then actually excise it from the chest. But now I actually divide it in the abdomen itself so that the thoracic part becomes much simpler, and I'll show you on the video. So this is robotic Ivor Lewis with circular anastomosis, and we'll start with basically mobilizing the left lobe of the liver. So you can use your left arm to actually even lift up the liver and mobilize the ligament. And then we start dissecting around the hiatus. And then we dissect on the right cruise by entering the lesser omentum. And then we move towards the left cruise. So you can see the right and left cruise. And making sure that now it's feasible, we'll move to the posterior part. We delineated, especially in terms of CEJ tumors, just to make sure. And then we'll start mobilizing the greater omentum, preserving the right gastroepiploic vessels. And then we'll divide the short gastrics. We'll now turn to dissecting the left gastric pedicle. And that's a left gastric pedicle. So it depends. If it's an SCC, then we don't need to do a detailed dissection around this area. And then we'll ligate the left gastric pedicle. And then we can start dissecting into the hiatus and into the mediastinum, lymph node station 1110 and 110 and 111. And then we try to do as much of the dissection as possible from the abdominal part to make our thoracic part much easier. So we go along the aorta, so lifting up the esophagus anteriorly, laterally now on the right side, and then superiorly. And then taking care not to disrupt the left pleura, but sometimes it's inevitable to hit that. And then we start making our pouch. And I said before, one of the tip is to keep the pouch narrow and uniform. So initially I used to just cut it almost just 3/4, and the last staple we will do that in the thorax, but now I do this entirely in the abdomen, and I'll show that later. So the next is the thoracic part. We'll dissect along the esophagus, the paroesophageal along the mediastinum, and then the subcarinal nodes, and that's the azygous vein. And then we'll divide the azygous vein. And then we'll pull the esophagus up to dissect a bit more. And then we continue with the lymph node dissection. Finally, we'll divide the esophagus and this was the circular stapling method that I was doing, and later I'll show you the hand sewn method. And then we use a purse string. We pass the anvil in. And then now we'll deliver the esophagus and stomach into the chest. And then we'll divide that last part. So this helps us to keep the orientation of the stomach. And then we'll make a posterior gastrotomy. And then we'll use a circular stapler 25. And then perform the anastomosis. We'll then close that gastrotomy. And then later on, we can put in some reinforcement stitches just to reinforce the anastomosis. And then we'll put 1 or 2 stitches from the stomach tube to the right and left crura to prevent a herniation of abdominal contents. So we'll just fix that to the crura there. So that's the circular stapling method. And then this is a hand-sewn method that I use. And this is a bit of a hybrid. This is just a few months before that I did this patient was a T4A, mid-esophageal CA, underwent neoadjuvant with cross. This was the tumor.
Oh, wow, I think the time is short. Can just speed up, please?
Okay, I have a minute or so. And this is it. I'll just move forward to just the small changes that I do. Is pretty similar to this part.
Yeah, show the circular, show the hand-sewn anastomosis maybe, huh?
Yeah. So here, see, this is an important part that I entirely take down. I staple it all across, and then I'll even divide the esophagus here and deliver the stomach side of the specimen through the abdomen. So that makes the robotic part much easier. So I'm taking the esophagus here and dividing it. And now this part I can deliver it through the umbilicus. And then I'm just going to oversew the stapler, and I'm just going to fix this stomach and the stomach tube. I'm going to shove it into the mediastinum here. So this esophagus you can pull up and you can dissect as much as you want, and it's not bulky, and you can actually see much better. So small tip to make your dissection much easier. So I leave it there, that tube there with a thread, and then do the thoracic part. And now you can see that you can actually just pull the esophagus up, and you can use the left arm of your robot to traction it, and you can go all around it and actually dissect it quite easily. And you can also take the margin as much as you want. In the meanwhile, you can send your proximal margin for frozen section, and you can make sure that whether it's negative or not, especially in lower third tumors. So having gone up the zygous vein, we divide that. And then I'm going to divide the esophagus there using a stapler. And that's the remnant of the esophagus. Now I'll pull the stomach up and then just join it for a hand sewn. So basically, just do a 2-layer with either Stratafix or V-lock, and then make a esophagotomy and a gastrotomy. And then the posterior layer first, and then the anterior layer. And then the second layer that we took the seromuscular layer, I'll close over that. So the robot helps here very much. And then finally, we can, I use this thing called as the NeoVil. It's a membrane to reinforce the anastomosis for high-risk anastomosis like rectum, esophagus, pancreas. And then I'll wrap the omentum around it. and this kind of decreases amount of leak rate.
Okay. I think because of the time, I think we have to stop here.
Yep. Thank you very much.
Thank you, everyone. Great video around. I think because of time, I think we only have 3 minutes, maybe just 1 or 2 burning questions. And
can I ask Do Jung?
Yeah, okay, that's the questions. Okay, sure.
You know, you did the scintigraphy study showing that 60% of the food goes through the stomach and 40% goes through the jejunum. Did you do many patients on this, or was it just one? And does it also depends on how you do the gastrojejunostomy, you know, whether it's on the side, anterior, posterior? Can I make some comments to that?
Yes, definitely. That data was based on the 30 patient, only small group. So as you said, it depends on the how we make gastrojejunostomy. So you're right.
So what are the tricks?
Some patients more than 70% passes through the remnant stoma, but some did another patient just less than 50. But I prefer the posterior wall gastrojejunostomy. I prefer as Professor Hyung-ho Kim. But the other surgeon prefer the anterior wall gastrojejunostomy or the greater curvature side gastrojejunostomy. So we need a study to compare that.
Okay.
Can I also ask about the indication for proximal gastrectomy and double tract? Of course, you are doing the randomized trial on early gastric cancer on proximal third cancer. But you know, we have recent data on EGJ junction tumors, especially the Japanese data, showing that even for T2 and T3 tumors, the incidence of nodal metastases to the distal part of the stomach is still very low. So would you be happy to do laparoscopic proximal with a double tract for EGJ junction tumors?
Yeah, sure. If for Gilbert type 2, if the size is less than 4 centimeter, we can accept the proximal gastrectomy for even T4A EG junction Gilbert type 2 cancer. However, in high body cancer, only early gastric cancer.
All right, thank you.
I have one question for Professor Hyung-ho Kim. Yeah, can you unmute? Yeah, the Hyung-ho, that we have a lot of locally advanced gastric cancer. So what are the cases you think it will be absolutely impossible for laparoscopic approach? You will do it open. What are the cases you will do open surgery in advanced gastric cancer?
I think the open surgery and laparoscopic surgery, that is just a way of the approach, not important. I think the less breathing surgery is most important. So when you do the laparoscopic procedure, sometimes we embed breathing. That times, no hesitation to convert to open. Open surgery is better at that time. Less breathing surgery is more important than laparoscopic or open surgery.
Yeah, I understand. Then bleeding, you get blood transfusions and get the immunosuppression. Yeah, thank you. I think we have to stop, I think, according to the Congress administrations. And then because Professor David Lomanto will give the plenary lecture, I would like to thank all of you and all of the faculty for the wonderful session. Also, thanks for the audience for joining us in this upper GI session. We have a great weekend. Thank you. Bye-bye.
Thank you, everybody. Thank you.
Bye. Thank you.
In person.